All right. Hello, and thank you for joining us for today's webinar on the Skilled Nursing Facility 5-Claim Sample Review Findings. Again, my name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education team. And I'm joined today by Rachel and Jennifer, and they're the other RNs on our team, as well as some members of our medical review department who will be assisting with the question and answers from today's call. So in this webinar, we're going to dive into some of those common review issues that we have been frequently identifying during the review of these 5 claim samples for skilled nursing facilities. Skilled nursing facilities play a crucial role in providing care and support to individuals with complex medical needs. And it's imperative that as these type of facilities, you are adhering to the highest standards of care and compliance. Reviewing the sample of claims submitted by these facilities is really going to help Medicare ensure that you guys are meeting the medically necessary criteria and that you're following the regulations. So these claims claim findings that we're going to discuss today are not inherently different than they were last month. The issues seem to, pretty much be staying the same. But if you missed last month's session, it'll be good to hear all this. Plus, the different thing in this month's session is that we're going to go through and look at some actual live documentation examples or a chart and some good and bad information that we get from the documentation. And we're doing this in an effort to help you avoid these common findings. So as I move on, this is our disclaimer. We have to show this disclaimer at the beginning of all of our sessions. And basically, disclaimer says, we prepared this education using Medicare rules and regulations. And those rules and regulations often change. It's your responsibility as a provider to make sure you are also following the most current laws, rules, and regulations as they are in place. We're going to provide responses to any questions based on the facts that you give us, but ultimately, Medicare rules will determine final coverage for anything, we say or cover today. Now, CMS also prohibits you from recording this event for any profit-making purposes. And since we don't know why you would be recording the event, we just ask if you are recording it to stop, or if you are making screenshots to please stop doing that as well. We are going to post this as an encore on our live events or on our encore page and on the YouTube channel. These are acronyms that I probably will refer to in this presentation or contained in various places in the slide deck. So if I happen to refer to an acronym or abbreviation that you don't know, just refer back to this. All right, the overall objective, my overall goal of today's webinar is to really equip you with a good understanding of the common review issues so that you can enhance your compliance efforts. And I really hope to accomplish this today by going through the review guidance on accurate documentation. We're going to talk about these common findings and the latest findings that our medical review department is seeing. And we're also going to look at some real life documentation examples. And hopefully that'll drive home some of these issues and how to avoid them. I want to start out by going through and talking about documentation guidance. When your claims are selected for review, how do you know what to submit? Well, on the screen and on your slide deck, if you printed it or have it in front of you, there are a few slides about documentation guidance. And this is basically the general information that you need to provide to us when we request claims for review. If you're watching this seminar live, we have some providers that are only listening, but if you're watching live or following along with the slide deck, you can see that there's an icon on the screen that looks like a computer. Embedded in that icon is actually a link to our website and to our documentation guidance. Now, hopefully this is going to pull up for me, but as I said earlier, my computer is not quite plain nice, but there are always a couple ways to get to things. And I am just going to pull this over and show you where it would link out to if my computer were plain nice. So on the WPS GHA website, under the Topic Center, under Medical Review, you're going to find information specifically about the Skilled Nursing Facility Probe and Educate reviews. So if I open the article in there, this is where that icon would take you to. And this contains all the documentation requirements that you need to submit when we request claims for review. This information is also included in your ADR letters. So whichever way you go out to get it, you know, we have made a list for you of the information that we need. I want to talk about this information, though, as we move on through these next couple of slides. Some of the biggest things that are often missed and that are really important to have in your documentation is your acute care discharge summary and transfer records. And any information that you're going to gather from that look back period that may have happened while your patient was in the acute care. If you're going to capture it on your MDS, it needs to be contained in the documentation. So things in the discharge summary and a transfer record that we also look for is if there was, for instance, use of the condition code DR to say you did not have a 3-day qualifying stay because there was maybe a public health emergency or some other kind of disaster that there was a waiver in effect for. We would need to look at the acute care information to see why that facility could not keep that patient for at least 3 midnights. And we're going to talk about that a little more as we go on. Also, admission records, where we're going to look for the diagnoses, the conditions that require skilled care. Remember, in order to provide skilled care, it needs to be for a condition that either caused the hospital stay or arose as a result of that hospital or skilled nursing facility stay. We're going to look for orders, progress notes from your physician, and then when it comes to nursing, we're going to look at all the documentation. Flow sheets, treatment records, progress notes, Medicare or medication administration records, etc. We're going to look for those plans of care that go along with all those departments as well, such as nursing. Social service, case management records, where are we trying to get this patient when they leave our skilled nursing facility. We're going to look at your nutrition records. We're going to look at dietary information, how your patient is doing with nutritional information. I already mentioned the MARs and the IV MARs as part of the nursing information. We're going to also, in the nursing information, look for activities of daily living. We're going to look at all of those records. They may be being charted on by your CNAs, but we're going to look to see how that patient is performing. And then when it comes to therapy services, PT, OT, SLP, we're going to look at everything. Evaluation, plan of care, all the progress notes, all the treatment records. And I stress evaluation and plan of care because regardless of what dates of service we request to review, we need your initial evaluations and plan of care. We need that information that happened when that person was initially admitted so we can go back and look to make sure that they're still following the plan of care that they initially prescribed for the patient, or we can see what changes have been made in that initial evaluation and plan of care, and that our progress notes are helping to show what has changed since the initial evaluation and overall plan of care. Treatment notes, treatment records, that helps with the actual minutes. We go back, we make sure that the minutes that you are reporting in the Medicare assessments, that the minutes you're reporting in the billing, we're making sure all of that matches. And then we get down to physician. We need all your physician certification, your physician notes, your plans of care, physician progress notes, any kind of diagnostic records, any kind of changes that have been made by the physician, and finally your MDS. All right. So we're moving on in the slide deck, and we're going to talk about some of these common findings. And I'm going through this kind of quickly because I want to make sure we have plenty of time to look at actual physical documentation and point out some things that are good and some things that are not so good in the documentation that we receive. So some of the common findings we often see with these skilled nursing facility 5-claim reviews, it's becoming pretty much repetitive. So services not supporting the level of service billed. I'll go through this list and then we'll kind of break down and talk about each of them individually. Conflicting documentation. When one department's saying one thing about a patient, another department's saying another thing. No hospital look-back information. And then we're still seeing some claims and having some issues with the use of the DR condition code without supporting documentation. So level of care issues, and that was the first issue I talked about. Start with some of the main things that we're seeing under level of care issues. And really it's the documentation that you're providing us is not supporting all the things that are on the MDS and all the things that are in the other components of your documentation. So we're not seeing the daily skilled service always being provided. Remember, a daily skilled service for nursing is 7 days a week, and for therapy is 5 days a week. Other issues, services performed by or under the supervision of a professional or technical personnel. This is really important when we look at things like therapy and the components of therapy that have to be provided by the actual therapist, such as changes to a plan of care or updates to a plan, progress notes, etc. Those are all things that have to be done by that professional person. If it's done by someone other than that, you're not meeting the basic requirements, and we can't consider it for coverage, so we would have to take it out of what you captured in your MDS when we're doing a review. We're not always seeing that the service was ordered by a physician. A lot of times this happens again in therapy when they decide to do something additional, but that additional information is not shared with the physician and ordered by the physician or okayed by the physician for them to perform. And then finally, services rendered for a condition related to the hospital or that arose in the skilled nursing facility for a condition treated in the hospital. So if you are capturing or adding diagnoses or adding treatment for services that weren't related to the condition they were in the hospital or arose from that in the SNF, then it can't be considered for coverage. When we talk about level of care issues in general and not supporting the level of service billed, let me tell you kind of what happens upon review. When we are doing a review of service, we have to extract your MDSs from the National Repository. And basically our nurse reviewers will go through your documentation and make sure that the things that you captured on your MDS match your documentation or support the level that you documented it at. If they don't, they basically have to recreate the MDS, and we could possibly pay you or usually end up paying you at a lesser level because we can't find all the services that you said you provided. All right, let's move on. And this kind of goes into what I was just talking about when we recreate. So the documentation not supporting the HIPS code that is actually billed. A lot of this sometimes happens when the look-back documentation isn't submitted. So remember, your look-back can be up to 30 days before that ARD in some situations. Sometimes it's 7 days, but majority of time that hospital information falls in there. So if you're going to capture things like IVs and medications and stuff that were administered in the hospital as part of your MDS, you have to make sure you also have that documentation to support that that actually happened. So if we can't see that that actually happened, we cannot in good faith pay you at that HIPS code billed. So just make sure, again, that you are accurately capturing and that the level billed is consistent with what is in your documentation. As we move on and talked about conflicting information. So information in the progress notes is sometimes different than what is actually captured in your MDS. And some of the biggest ones we've seen are pressure ulcer information and items to reduce pressure and self-care assessments. So that information is perhaps captured on the MDS, but we're not seeing it in the documentation. Another issue is when the therapy functional ability vastly differs than what nursing is reporting. So we know as nurses and as nurse reviewers that often what a patient can do with a therapy service is going to be different than what they can do with the nursing service. Maybe if they're having therapy during the day and they're getting adequate pain relief, they're able to function better with therapy than they are in the night shift or the evening shift with nursing. Maybe their ability to ambulate is way different or, you know, different because of pain, because of swelling, because of whatever issues, just general fatigue from being in therapy services all day. What we see in your documentation is some of that information. Do we have increased fatigue? Do we have increased pain? What is nursing doing, you know, that makes the patient now a 2-person full assist when, you know, in the evening when physical therapy maybe was reporting during the day, they were a one-person contact guard assist when ambulating. So if we see that additional information, if we see that additional pain, or maybe maybe the pain medication is too much, so they are in a state where the pain medication has kicked in and caused some cognitive functioning deficit that they don't really stand, those are the things that we expect to see different. And then, or, you know, noted in the documentation to support that difference. And then we would expect as nursing in the plans of care, you are also then identifying what's some carryover information we could take away from our therapies that our nursing staff, that our CNAs can do to support their therapy levels of care. So those are just a few of the things that I wanted to highlight with that. Again, we know differences happen, and we expect a lot of times, especially when there's an injury or an accident that has sent that person to your skilled nursing facility, that there's going to be, you know, differences. But when they're, you know, one person's saying they're independent and the other person's saying 2+, that's when we're like, well, who's right in this case? And if they're both right, then what's the difference? And so that's what you need to document, what the difference is. Okay, now finally, and I brought this up last month as well, we still have issues because we're still seeing some claims come in with the use of the DR condition code. So the things that I want to point out about the DR condition code. The DR is a condition code when there is, it's disaster related is what it means. So this DR condition code most recently was in effect during the 1135 waiver for the public health emergency related to COVID-19. As part of this DR condition code, the information for skilled nursing facilities to use this DR condition code was that there has to be, if there's a reason related to, at that time, the public health emergency, that the acute hospital could not keep the patient for 3 qualifying midnights, then the skilled nursing facilities had the availability to take the patient in, to admit them before there was 3 qualifying midnights and use the DR condition code. The thing about that, and I stress this because we could have another 1135 waiver for a lot of different things, for natural disasters like fires or floods or tornadoes, or if, you know, God forbid we have another public health emergency due to a pandemic. And that 1135 waiver could be issued and the DR condition code could go back into effect, which allows, you know, again, for a SNF to admit a patient before completing the whole course of hospital treatment, or a diversion from the hospital altogether, meaning they're a direct admit to the SNF. But the kicker with this is that as the skilled nursing facility that's using this code and saying, hey, we went outside the normal regulations of the 3-day qualifying hospital stay, the burden of proof lies with you to support the use of that code. Again, we go back to the hospital notes. What do we have? What information do we have from the transferring facility or from the acute facility that says they were not able to keep the patient or admit the patient due to something that affected the DR condition code? So just saying there was a CMS waiver in effect is not enough. As we all know, once we were towards the end of the public health emergency or the expiration of the waiver, which ended in May, we had hospitals and skilled nursing facilities that very much could keep the regulations, the 3-day qualifying stays, you know, those patients in the acute hospital stay, you know, just fine. There was no reason for them not to have that 3-day qualifying stay. There was no reason for diversion of the hospital unless that hospital did not have bed availability or the hospitals around no bed availability, no. Staffing shortages, whatever. If that was the case, we need to see that information. We need to see why the hospital couldn't complete the full course of hospital treatment or why they diverted. So that's the information that the skilled nursing facility needs to have and prove. And again, I bring this up and I stress this because we did and still continue to do denials for these claims. On claims that were admit to discharge and maybe had within that 100 days, you know, if they had 100 days of service, and they're just now dropping their claims to Medicare, we're still seeing the use of some of the DR. So those related to the public health emergency will finally start to trickle off, you know, by the end or by mid next year, because facilities have a year to bill. So again, I bring it up because it could go back into effect. And I want you guys to be equipped with the knowledge of how to avoid getting a denial for the use of the DR condition code. All right. So now we're going to switch gears a little bit and give me just a second to pull in some information, and we are going to look at some actual documentation that was submitted. Now this happens to be, if my computer's going to play nice, this happens to be all this information from the same chart, but it is good information to share with you. And I am going to ask Rachel, can you verify that you are seeing a claim up on the screen?
Yes.
All right, perfect. All right. So briefly go through some information. This first one, since we just got done talking about the DR condition code, I want to show you what the issue was with this specific chart. So you can see this is an admit to discharge bill. It's billed under the 214. They did bill the DR condition code. I don't have in 35 or 36 a 70 span for the hospital stay, but we are going to talk about that as we go through here. In this actual bit of information, you can see that their a current span code 50, which is consistent with what they are calling their admit date was their ADR date was 4/7/23. And you'll see as we go through some of the things about that as well. And so for this particular claim, they billed 10 days. So 10 units were billed. And they had, under this particular month of service, 8 units of occupational therapy and 7 units of speech language pathology. So down here are then the diagnoses for this patient. So the main diagnoses for this patient is other displaced fracture of the upper end of the left humerus, subsequent encounter for fracture with routine healing. And then we have essential hypertension, vitamin D deficiency, the history of falling, hyperlipidemia, which unspecified, and then finally unspecified dementia with an unspecified severity without behavioral disturbances or psychotic disturbance or mood disturbance or anxiety. All right, so as we move on, I'm going to show you information from the hospital's discharge sheet. And all of the information, protected health information about this patient has been sanitized out. So, interesting things to point out. It's an 82-year-old female. Here's all those diagnoses that we talked about. She went to the ER with a closed comminuted fracture of the humeral head and neck, and had mild displacement from a fall at home. And the fall, and I get some of this information from other places in the chart, where she missed a chair. And when she fell, she hit her left side and her forearm. Ironically, this poor lady had another fall 6 weeks prior to this, which caused a fracture of the right wrist. And so she's status post ORIF surgical repair of that right distal radius on February 6th of 2023. Now, she also hit her head when she fell, so she did have some head injury, but the CT was negative. So pertinent review of systems were pain of the left arm and shoulder and the head injury. But we come to later find out that that again was negative. So this goes through, and it goes through some allergies, and it goes through her current medications and her vital signs, etc. So this gives an overview of the information while she was in the hospital. So I'm just kind of scrolling down fast. So if that bothers you, look away while I'm scrolling. She had a bone density scan that was done after that right distal radius fracture. So if you go through and read the results of the bone density scan, she does have some osteoporosis, which is, you know, statistically significant for decrease in bone mineral density, etc. If you look at the shoulder x-rays, it goes through and tells you, you know, what they saw upon x-ray. And then the CT of the head gives you some information that there's nothing acute related to her, you know, hitting her head. She does have some other changes consistent with atrophy, you know, obviously, which explains the dementia that they have pointed out. All right. If we go through here, so she was admitted to the med-surg floor, fall precautions, ortho consult. They decided she was non-surgical. She was going to be non-weight bearing of that extremity, and that extremity would be placed in a sling. Now remember, now she has a left and a right injury. She's hemodynamically stable, but she was cleared for surgery if needed. They have an attestation for the 2 midnights that they felt that she would need to stay for at least 2 midnights in the facility. And she was admitted on the 14th and discharged on the 16th. So she has midnight of the 14th, midnight of the 15th, and she is admitted to the skilled nursing facility on the 16th. So we do not have 3 midnight qualifying hospital stay. The facility appended the DR and their reasoning in the documentation was Medicare waiver. So no information to support why the facility couldn't keep her, why she didn't stay for at least 3 qualifying stays, what part of the pandemic was causing them to discharge her from the facility early and send her to the SNF. Was there lack of bed availability? Was there lack of nursing services? You know, was there a walkout at this facility? We don't know. There's nothing here to support why the patient couldn't stay. And so in this case, unfortunately, the claim is going to be denied because we're not meeting that general requirement and we're not supporting why the DR condition code was in effect. So I'm going to give a little bit additional information about this patient before we look at some more information. So if the patient had the 3-day qualifying stay, we're going to go through and look at some other documentation things. The documentation did support an ortho consult at the hospital, which again recommended non-weight bearing. Physical and occupational therapy were ordered for this patient to follow up with. And then the patient was to return to the office in 2 to 3 weeks. So the physical exam by the ortho physician also stated that this was a pleasant 82-year-old woman, alert and oriented ×3. Physical therapy in the hospital, they did focus on range of motion, active tolerance training, some balance training, bed mobility, equipment education, therapeutic exercise. They advised the patient continue at least 5 days a week with therapy services. We find that in the hospital, physical therapy notes that the patient moved in with the daughter due to a gas leak in her independent living apartment. And when she moved in with the daughter, that's when she sustained the first fall and fracture of the right wrist. Prior to that, she was independent with functional mobility. She did use a cane, but has been using a 4-wheeled walker since the fall in February. And she does require some assistance with ADLs after that. The daughter and son-in-law also work, so the patient doesn't have 24/7 support. And then the PT notes also showed lots of support is needed with bed mobility and transfers, especially with the sitting to standing. Her balance tests were good for sitting and fair for standing. And there was no notes, OT notes from the hospital, no speech language notes, etc. And she was admitted to the skilled nursing facility on 3/16 and discharged on 6/11. Now, the dates of service that we were reviewing were the June dates of service. So again, we're going to move on and look at the MDS. As I stated back here, her discharge date from the hospital was 3/16, and that was her same admit date to the skilled nursing facility. So the first thing that I noticed when I looked at this is that the assessment reference date was set at 4/7/23. So I needed to go back and figure out what happened between 3/16 and 4/7. Well, this patient actually happened to be on a Medicare Advantage plan that she switched back to traditional Medicare, which went into effect 4/1. And so her ARD date was then considered timely based on that change. So if you were wondering that, don't worry, I was wondering that too. I was like, what happened here? The so that was the case. Now I'm going to scroll down and, we have our Section A information and our demographic information, et cetera. And that's where I found a little bit of information back here about, yes, it's the 5-day assessment, but it wasn't the, quite the admission, because this information was based on the fact that they changed payer sources. All right. So we scroll down, and the first thing I just want to point out, and excuse me for going so fast, I'm going to go to Section B. Because when this patient entered the skilled nursing facility, one of the things that got ordered and was on the dates of service under review was speech language pathology. So I'm looking at the hospital notes, and I'm looking at what happened there and why speech language was ordered when there was no deficits noted. There is some dementia issues, but they did not report any kind of cognition stuff, even on initial assessment and the MDS assessment. So as we look through the speech and hearing, I want to see, do we have a speech issue? Is the person, do we have any kind of speech clarity, any kind of hearing, any kind of ability to understand? And this is all being marked no, no, no. Then I'm thinking, okay, is there some cognition issues? And there is some cognition issues. And she is able to go through, and they do the BIMs, and she's able to repeat those words. But then she has some issues as you read through this with the recall, which is fine. And that's probably, obviously part of the cognitive issues. So we go through, and I'm going to go down to Section E, and some of the issues that, I was concerned with are any kind of behavioral issues, potential for psychosis, anything that would go back to, lead me back to additional cognitive issues that may require some speech language pathology. And there's nothing else listed here. So then as we scroll down, now we know that Section G and Section GG are now combined as of October 1st. And as we're talking about this, some of the issues or some of the things to bring up or note about Section GG is what goes into your payment. What are some of the things? Well, some of it is your overall assessment that takes place, when we go down into Section GG, sorry. And again, these sections are now combined, so make sure you're using the most current version that has the combined G and GG. So your assessment period, days, all the information about the patient's independence, et cetera. Make sure that is all completed, because that all plays into part of the payment. When we scroll down into the self-care issues, the self-care like A, B, and C and self-care, those play a huge part in your payment as well. And I may have scrolled through it fast because I'm just trying to get through it. It's G030. So yeah, all the functional ability and self-care information. Oh, sorry, there goes my computer just doing something fast that I didn't ask it to do. That plays a part. The mobility information. So all of this information on the patient's mobility, make sure that you are identifying this, because that goes into the payment as well. So really make sure you're focusing on that. And we make sure that we're focusing on that too. So if you're marking it in your documentation as present or as an issue, we are looking for it in your documentation as well. So your rolling, your fit to line, etc. All right. So under active diagnoses, I'm going to scroll down to section I, and bear with me, HI, here we go. Under active diagnoses, one thing that I do want to point out, and this one is, we know this person was admitted for a humerus fracture, and then they had an old fracture of the other wrist. So this person was coded as fracture and other multiple trauma on this section. And I'm just looking at some notes. There was, at one point, and there we go, where they did mark hip fracture, but there's no indication of hip fracture. So just be careful what you are marking and that you are choosing things appropriately. This section happens to be diagnosis listed in the parentheses provided as an example, should not be considered for the all-inclusive list. These are things in the last 7 days. So in this one, hip fracture did get marked. This person didn't come for a hip fracture. It probably should have been other fracture. There's no information on this one in section J for the falls or fractures or anything related to the falls that is pertinent for this patient. So be leery of that. And then K through Z, no swallowing disorders, no information about swallowing, feeding, etc. And then this was not an admit to discharge MDS. They did do a separate discharge MDS on this patient. And then finally, the last piece of documentation that I want to show you and bring up is the certification information. As I kind of pointed out, one of the issues that I saw with this patient and I saw with the overall documentation is the SLP services. So kind of make me wonder right from the beginning, okay, what was speech added for? And so we have to keep digging in the chart and finding the information. So let's talk about the general certification and certification requirements. Initial certification for skilled nursing facility is due at the time of admission, and then there's a 14-day, and then there's every 30 days following whenever the 14-day was signed, so on or before the 14th day, etc. We do often see the initial and the 14-day done on the same day, and that's okay. It happens. It's allowable. Is it ideal? Maybe, maybe not, but we do see that happen. So this one happens to be the initial certification for this patient. So they're saying that the skilled nursing facility was needed for physical therapy and for functional mobility and occupational therapy for self-care, which would make sense because we have a patient with 2 bad limbs, and which is going to really affect their ability to ambulate, to move successfully, to move around in the bed successfully, to sit, to stand without being able to put pressure on both arms, etc. And then also continue to do their own self-cares or help with their own self-cares if they have one hand that initially was still in a cast when they started, and then another arm that's in a sling. So here's what was initially ordered and certified as far as rehabilitative therapy services go. And it was certified by the physician, it was signed off, and that was done on April 10th. Now remember, we have an admit date of 3/16, but they didn't start traditional Medicare till 4/1. The MDS was done on 4/7, and we have a physician certifying that on 4/10. So this moves on for the 14th day. Now, when we're doing secondary certifications, we really need to have more information than PT or OT. They do an okay job with saying that PT is needed for functional ability and OT is needed for self-care, but really it would behoove your providers to give more information. What do we want in the functional ability? Are we working on ambulation, bed mobility, etc., occupational therapy? What specifically in self-care? Are we working on our ADLs? Are there specific self-care items that we want to work on? So we do pay attention to that, and we hope that you encourage your providers to provide more information there. Again, you can see in this certification that it was signed off on the same day, which is allowable, and they've given us some indication for what they, continue to do. So then as we move on, the next certification should be within 30 days of this date. So since it was signed off on 4/10, we need to have the next certification no later than 30 days from 4/10. And you can see here, there's no reason given. So they tell us PT and OT down here, and now they've added in speech language pathology. And under here, speech language for a displaced fracture of the upper end of the left humerus, subsequent encounter with routine healing, and then cognitive communication. Well, speech language has nothing to do with treating the displaced fracture of the humerus. They can do some work for cognitive, but we really need information to support that. And that really should be explained up here in detail of why that was added. And then finally, they say ST, and this is the last one, and it has to be 30 days from whenever the prior one was signed, so 30 days from 5/3 or within 30 days. So speech language pathology is being added for cognition, but again, we don't really have the information on the reasoning. Again, down here, they start with the displaced humerus fracture and then just say cognitive communication. So you really need to be mindful of what is being documented, and your physicians need to be given the reason why they are certifying that patient, or that reasoning. If it's not listed here, it needs to be in that physician's progress note to go along with it. So just a few other things about additional information about the documentation we received. All documentation was provided from the initial assessment through the end date. The OT documentation was beautiful. We had the evaluation and treatment and the plan of care and the goals, interventions, etc. We had no PT documentation. We had no speech language documentation. So even though there was speech language and OT that were provided during our review period, we did not have that documentation to support it. Now, like I said, this claim ultimately ended up being a denial because of the DR condition code anyways, but we didn't have any documentation to support those other services had they not needed to or not used the DR condition code. So I know that was a lot of information, and we are very close to call end time. And I have glanced at the chat, and I do not see any questions in the chat at this time. So thanks for sticking with me for these extra couple of minutes. On behalf of myself, Jennifer and Rachel, and all of Medical Review, we want to thank you for your participation in today's event. We look forward to your survey comments, and we hope that you join us for future events. And at this time, you may now disconnect.